Hello everyone. Today we are going to discuss about a lab parameter ALP, that is alkaline phosphatase, which is very often utilized in clinical practice. So we will discuss about that in detail. So first of all, what is ALP? As the name indicates, alkaline phosphatase. So it is an enzyme molecule. So enzyme in the sense it will be a sequence of amino acids. So as we all know, what will be the function of an enzyme? It will break down something. So here this alkaline phosphatase will break down organic phosphate ester compounds. So it breaks organic phosphate ester compounds. So where do we see these compounds commonly? These are there in our extracellular fluid. So there this enzyme will break down these compounds. But the thing is, its exact utility is not known. So the exact function is unknown, because breaking down of these compounds, how does it help to our body is not yet known. But we got to know that alkaline phosphatase enzyme is there in the extracellular fluid. So how did it reach the extracellular fluid? So what are the sources of this enzyme? This we can divide it into two things. One is tissue specific. One more is tissue non-specific. So these are the sources we can consider. Tissue specific in the sense mainly the placenta, intestine and germinal tissue. These are the reasons for alkaline phosphatase, which is considered as tissue specific. But the thing is, these sources will not contribute much to the extracellular fluid levels of ALP. So contribution is lesser from this aspect. Whereas when we discuss about tissue non-specific source of ALP, mainly it is distributed everywhere, but most often it is seen over bones and the cytosol and the surface of hepatocytes. So in the liver, it will be there in the cytosol and surface of hepatocytes. So these two sources, which are considered among tissue non-specific, contributes to more level of serum alkaline phosphatase. So this is very important for us, this aspect. Now once we got the sources of alkaline phosphatase in the extracellular fluid, we have to consider some conditions which will lead to its increased levels. So for this we can go point by point considering each of the sources. For example, increased levels are seen because of placenta. We can consider a physiological rise of pregnancy, right? Specifically in third trimester. Coming to the second source, that is intestine. So here the point is, commonly after fatty meals, there will be raised levels of alkaline phosphatase. That's why it is a basic sense that alkaline phosphatase should be measured in fasting state. So this is the importance. And one more clinical implication is, whenever there is intestinal obstruction, there will be a rise in ALP levels. And the point here is, This raised levels will take minimum 7 days to get cleared from serum levels. That's why the levels will remain raised for up to 7 days even after relieving the obstruction. So this is the clinical implication. Sometimes from surgical department, even after relieving intestinal obstruction, there will be raised ALP. For that, physicians might get reference. So there we have to follow wait and watch policy, as it will take 7 days to get cleared from the serum levels. This is about intestinal reasons for raised ALP levels. Coming to germinal tissue and the bones, we can consider some conditions such as childhood and puberty, right? So here in these conditions, because of bone growth, we can observe raised levels of alkaline phosphatase. Coming to the final source, that is liver, commonly in hepatobiliary disorders. Hepatobiliary disorders, we will get raised levels of alkaline phosphatase. So these are some conditions which we have to consider whenever we get increased levels. The next aspect about today's topic is the lab analysis basics. That means what we should know before considering ALP levels. First thing is we have to prefer fasting sample. Why is it so? Because after meals, if we send, we know that there will be physiological rise in the ALP levels. So always prefer fasting sample, and when it is being analyzed, don't delay in analysis, because it will give falsely high levels if sample analysis is delayed. This is the second point. Third important point is the measuring unit. We all know that it will be international units per liter. This is the measuring unit for ALP levels. So these minimum lab analysis basics one should know about ALP. Now how to analyze the report. This is very, very important when we get liver function test. So we know that the normal levels of the enzyme is 40 to 140 international units per liter. So this is the normal levels, and whenever we get increased levels, we have to find out the source. Among source, we have already discussed mainly 5 things, whether it is placenta or germinal tissue, intestine, bone, or more commonly liver. So find out the source. This is very important, and that will be done based on the history part mainly. We have to check for the co-elevation of some other molecules like GGT. If it is elevated, it indicates that it is probably liver or biliary disorder. And similarly, one more molecule, that is 5-nucleotidase. Suppose this is increased, it is very helpful in finding out liver disease. If both of these are normal, we have to consider some bone disorders. Right? Because we have ruled out the conditions related to intestine, placenta, and germinal tissue. So we are left with only bones and the hepatobiliary system. So this differentiating point we can utilize to find out the source. Now the thing is, suppose the enzyme levels are increased but not more than 50%. So when there is less than 50% increase, remember, don't do extensive workup. It doesn't require much workup. So just it will need follow. This is when there is no much significant elevation in alkaline phosphatase. So what is that significant elevation? We consider significant elevation if the levels are more than 4 times of upper limit of normal. So in this situation, we have to consider some cholestasis. This is the point. So when there is levels of more than 4 times, consider cholestasis. So what we can do in that situation? We have to get ultrasonography of abdomen first to look for bile duct dilatation. Suppose in ultrasound we get it as dilated bile duct. So the next step will be considering ERCP or MRCP. Suppose it is not dilated. In USG, there is no dilatation of bile duct, not dilated. In that case, we have to send for AMA levels, that is anti-mitochondrial antibodies for primary biliary cirrhosis. Suppose it comes as negative, then the other causes of intrahepatic cholestasis should be considered. Intrahepatic cholestasis. And in any situation, if we don't get a conclusion, we can consider liver biopsy as last measure. So this should be the approach whenever we get significant elevation of alkaline phosphatase levels. Now here we will discuss one important aspect which is not often considered in clinical practice, but again it can be an important clue for diagnosis of some rare conditions. That is, when we see low levels of alkaline phosphatase, lower than the normal, is it to be ignored or some conditions to be considered? It should not be ignored. Instead, we have to consider some conditions like Wilson's disease or zinc deficiency in that individual, or hypothyroidism, then pernicious anemia, or congenital low ALP levels. So these are some conditions which can lead to low ALP levels. So the overall point here to summarize about ALP is, first of all, it is an enzyme which is often seen in liver function test reports, and this enzyme will break organic phosphate ester compounds in the serum, that is extracellular fluid, but the exact function of this molecule is not known. And regarding the sources, we can divide it into tissue specific, tissue non-specific. Tissue specific will not contribute much to the serum levels. Important thing is tissue non-specific, where bones and liver are the major sources. So according to each source, we can consider some conditions in which this enzyme will be elevated. So those conditions we can see. Here clinical implication is that after fatty meals, it will be physiologically increased. So always consider fasting sample when we want to analyze alkaline phosphatase. And the measuring unit is international units per liter. And when we get liver function test report, specifically alkaline phosphatase, how to analyze? Check for the normal levels. If it is increased, find out the source. And to differentiate tissue non-specific sources, take help of GGT 5-nucleotidase. So if either of them are increased, consider liver pathologies. If they are normal, probably some bone disorders are the reasons. And when it is not elevated significantly, don't do extensive workup. Just it requires follow-up. But when there is more than 4 times elevation, then we have to consider cholestasis. So the further workup will be to find out is there any duct dilatation through ultrasonography. If it is dilated, do further workup of using ERCP, MRCP. If the duct is not dilated but still we are considering cholestasis, we have to send for AMA levels for primary biliary cirrhosis. Suppose it comes as negative, consider other intrahepatic cholestasis as the possible reason. And the last option, if we didn't get any cause for the elevated levels, we have to consider liver biopsy. And at last we discussed some reasons for low levels of ALP, which is not often discussed. So this is the overall summary about alkaline phosphatase. Hope you all got the point. If you understood the concept and if you are liking the information on our channel, please consider sharing among your friends. Also, subscribe to our channel so that we can come up with such informative and detailed videos on our channel for you guys. Thank you so much. See you in next video.